Welcome to Pediatric Podcast for PedsCases.com.
Welcome to Approach to Pediatric Vitiligo, a podcast made for PedsCases.com at the University of Alberta.
I'm Dr. Harry Liu, a dermatology resident doctor at the University of British Columbia.
And I am Sarah Choi, a medical student at the University of British Columbia. This podcast will provide an organized approach to understand pediatric vitiligo, a very common pediatric skin condition. We would like to thank Dr. Wingfield Remus for developing this podcast with us. Dr. Remus is a pediatric dermatologist from BC Children's Hospital and also a professor in the Department of Dermatology and Skin Science at the University of British Columbia in Vancouver, Canada. After listening to this podcast, we expect the learner to be able to 1. Describe the typical clinical presentation of pediatric vitiligo, including key features on history and physical exam. 2. Discuss the underlying pathophysiology of vitiligo and recall its common subtypes. 3. Generate a differential diagnosis for pediatric vitiligo. 4. Discuss the psychosocial impact of vitiligo. 5. List available resources for patients. And lastly, 6. Review various treatment modalities for pediatric vitiligo and determine the factors that may influence treatment choice. Let's start our discussion with a case. You are a third-year medical student on your pediatric outpatient rotation. Your first patient of the day is Annika, who is a 6-year-old girl and a new immigrant originally from Nigeria. Annika's mother tells you that Annika started having some white spots on the dorsal aspects of her hands and jaw about 8 months ago. They did not seek medical attention because Annika was completely asymptomatic without pain or itchiness. Before the rash started, the family was going through a lot of stress with moving to a new country. However, there is no history of skin infection or trauma. Over the past 2 months, the size of these spots have significantly increased. The white spots are very noticeable with Annika's darker complexion. Her mother is extremely worried that they could spread to the rest of her body, and she is worried about how Annika will be treated at school since she is going into grade 1 in a few months. Upon further history, Annika has no family history of similar skin findings, but her mother has type 1 diabetes and hypothyroidism from Hashimoto's thyroiditis. Annika is otherwise healthy with a normal birth history. She met all of her developmental milestones and is not taking any medications. On skin examination, there are irregularly shaped, sharply demarcated, milky white, non-erythematous, and non-scaly patches with convex border lateral to the lower vermilion border, one on each side and symmetrically distributed. The texture of her skin has not changed. The patches on the dorsal aspects of her hands share the same morphology. You do a complete skin examination and you do not find any other lesions. The rest of the physical examination is also unremarkable. The total area of the rash you estimate is about 2% of total body surface area, and being an astute medical student, you believe that Annika could have vitiligo. Vitiligo is the most common cause for depigmentation, and it affects 0.1 to 2% of the general population. The prevalence of vitiligo increases with age, and 1/2 of cases will present before the age of 20. The peak incidents are in the second and third decade of life. However, it is important to recognize that vitiligo has no predilection towards a specific gender or ethnicity. The cause of vitiligo is multifactorial, and it is associated with multiple risk factors. First, vitiligo is a polygenic condition, and there are approximately 36 gene loci associated with vitiligo, and these genes are involved in melanin biosynthesis, immune regulation, or apoptosis. Therefore, a positive family history and the presence of other autoimmune diseases, including autoimmune thyroid disease, alopecia areata, psoriasis, and inflammatory bowel disease are significant risk factors. Vitiligo is also associated with rare genetic conditions in some cases. The concordance rate of only 23% in monozygotic twins highlights the presence of other non-genetic or environmental factors. Patients have reported associated events before the onset of disease, including physical illness, skin trauma, called Koebner phenomenon, sunburn, or even emotional stress, which is relevant for Annika as she was moving from Nigeria to Canada. In adults, pregnancy can also be another triggering event. The current understanding is that there are multiple mechanisms contributing to the development of vitiligo, with autoimmunity being the most important one. Vitiligo is classified as an autoimmune condition in which predominantly autoreactive cytotoxic CD8 positive T cells target melanocytes, which produce melanin, a dark pigment responsible for skin color. Studies have shown an increased level of cytokine expression such as TNF-alpha, IL-10, IL-17, and interferon gamma in depigmented skin areas, which further support the role of immune system in vitiligo.
Vitiligo is a heterogeneous condition that can have variable presentations. The most common initial presentation is flat, white macules and patches in periorificial areas, including the mouth, eyes, nostrils, umbilicus, and genital area. The macules and patches appear milky white, with well-defined convex borders surrounded by normal skin. It is important to note that vitiligo may show more than one shade of color. Although the location, size, and shape of depigmentation vary, it is often bilateral and asymptomatic. Depigmentation defines total loss of melanin caused by melanocyte destruction, whereas hypopigmentation defines partial loss of melanin pigment. It can sometimes be challenging to clinically differentiate depigmentation from hypopigmentation in patients with pale skin. However, there are tools like Wood's lamp that we can use to aid in diagnosis. Besides color change, inflammation is rare, therefore should not be associated with changes in skin texture. Other commonly affected sites include extensor surfaces, sun-exposed areas, and areas of frequent cutaneous trauma, such as the elbows, knees, and shins. Areas of depigmentation can expand over time. Leukotrichia can also be seen in the affected skin, which is a poor prognostic sign. Vitiligo can be broadly classified into non-segmental and segmental vitiligo. Non-segmental vitiligo is more common and comprises 80% of total cases. The classifying feature being that the white patches of depigmentation are seen all over the body and often in a symmetric pattern. Non-segmental vitiligo is further broken down into 5 subcategories. Number 1. Generalized vitiligo involves symmetrical and bilateral depigmented patches of skin in multiple areas of the body. Onsets usually before age 30. Number 2. Acral or acrofacial vitiligo defines a pattern of lesions that are on the face or at distal extremities. Number 3. Focal vitiligo refers to isolated area of skin depigmentation. Number 4. Mucosal vitiligo indicates an involvement of the oral or genital mucosa. Number 5. Universal vitiligo defines cases in which it's an almost complete depigmentation of over 60 to 90% of the body. Segmental vitiligo often presents in childhood and is classified as asymmetrical and distributed in a true or pseudodermatome pattern, most commonly along the distribution of the trigeminal nerve. Segmental vitiligo is unique in the case that isolated areas of depigmentation stop growing within 1 year and the risk of expansion is low. It is essential to recognize and identify different types of vitiligo because it may alter the course of management. Vitiligo is usually a clinical diagnosis with proper history and characteristic morphology. A Wood's lamp emitting UVA light at 365 nanometer wavelength can be used to confirm the diagnosis. Especially useful for patients with pale skin. You'll see vitiligo lesions fluoresce blue and white with well-demarcated borders. It'll be useful to physically demonstrate this to patients and make sure they're aware that the same phenomenon will occur when they're under black light in different settings, including glow bowling, laser tag, and so on. Under dermoscopy, you might see residual perifollicular pigmentation and telangiectasia in the depigmented area. A skin biopsy is not routinely done, but can be performed to differentiate vitiligo from other depigmentation conditions if necessary. If laboratory confirmation is needed, you'll want to biopsy the border of the lesion to include both normal and depigmented skin. Biopsy for vitiligo will reveal complete absence of melanocytes and a loss of melanin pigment. Furthermore, immunohistochemistry will show increased CD8 staining in lesional areas. Approximately 15 to 25% of patients with vitiligo are affected by at least one other autoimmune condition. Screening for thyroid disease is recommended for all patients due to its prevalence. It is important to watch out for symptoms of other associated autoimmune disease, including pernicious anemia, Addison's disease, and type 1 diabetes. The significant psychological impacts associated with vitiligo. Patients may experience stigmatization and isolation, which significantly impact the patient's quality of life. It is important to consider and explore the psychosocial impacts of vitiligo at the time of diagnosis with regular follow-up onwards. This will be discussed in the later sections. Although vitiligo is the most common diagnosis for white macule or patch, there's a list of differential diagnoses you need to consider. We will talk about them one by one. Nevus depigmentosis is a congenital hypopigmentation condition. Associated skin lesions are non-progressive and benign, and usually present at birth. Pityriasis alba presents with hypopigmented areas that appear to have a scaly texture. Most lesions are found on the face, but some exposed areas are also commonly affected sites. Post-inflammatory hypopigmentation is acquired after inflammation or trauma to the skin. There's a temporary decrease in pigmentation in these areas due to melanocyte damage or changes in melanin production. Abnormal pigmentation can occur after wound healing, as scars repigmentation is unpredictable. Scars, especially from chronic excoriation, can sometimes become depigmented due to the constant physical trauma to the melanocytes. This can be delineated from the history. Halo nevus is a melanocytic nevus that is surrounded by a round or oval area of depigmentation. Tinea versicolor presents with pale, scaly macules caused by superficial yeast infections. Tinea versicolor often presents in the chest and upper trunk. The rash has seasonal variation and is exacerbated by sweat. Under a wood lamp, the skin area will appear golden yellow. Pybodism is a rare congenital depigmentation disorder. It is characteristic for localized midline depigmentation on the forehead and the forelock.
Before discussing treatment options, it is very important to know that there is no cure for vitiligo, and the main goals of treatment are to slow down progression, promote repigmentation, and minimize the visible changes in skin color. It is very important to have an honest discussion with the patient about the nature of the disease and their expectations, so you can work together to determine what is the most optimal treatment option. Some patients may choose to not treat vitiligo. Most cases of pediatric vitiligo are managed by family physicians. However, a dermatology referral should be considered in the following cases. 1. A diagnosis is in question. 2. The family physician does not have sufficient experience to treat vitiligo. 3. A rapidly progressive disease. 4. Significant involvement of total body surface area. And 5. Lack of satisfactory response to treatment after a reasonable amount of time, which is usually 3 months. Now, let's move on to the discussion of what treatment options are available for vitiligo. A diagnosis of vitiligo can have significant and lifelong impacts on patients, as it is associated with increased stigma and significant emotional and psychological distress. Patients may experience shame, low self-esteem, and social isolation. Putting the condition into cultural context, some cultures believed it was a form of punishment or white leprosy. It is important to recognize and acknowledge the possibility of psychosocial impact when planning management. Going back to our case, Annika's mother is already worried about how the condition can impact her general well-being. As Annika has a darker skin complexion, depigmented lesions will be more noticeable than in a patient with lighter complexion. It is more important to discuss the implication of the diagnosis and connect them with patient advocacy and support programs. Some of them include Changing Faces, which is a UK leading charity for everyone with a scar, mark, or condition on their face or body that makes them look different. There's also Vitiligo Support International, which is a patient-driven nonprofit organization which offers a comprehensive resource of vitiligo education, research, and awareness for those whose lives have been affected by vitiligo. And lastly, there is the Vitiligo Research Foundation, which is a registered nonprofit organization funding fast-tracking medical research globally to develop effective treatments for millions of people around the world who suffer from vitiligo. There has been increased exposure and awareness of vitiligo in current media. For example, Canadian fashion model Winnie Harlow is recognized internationally as a vocal advocate of body confidence. She frequently provides honest and inspiring accounts of living with vitiligo. This can be very powerful to be shared with teenage patients and their caregivers. First and foremost, sun protection or sun avoidance is crucial. Melanin serves an important photoprotective role against DNA damage by absorbing ultraviolet radiation. Thus, depigmented areas of skin are at higher risk for sunburn and skin cancer. Additionally, sun protection prevents increased pigmentation of unaffected areas and thus reduces the contrast between affected and unaffected skin. Sunscreen, sunglasses, hats, and clothing protection are effective methods of sun safety. Broad-spectrum sunscreens with a high sun protective factor of at least 30 is strongly recommended for patients with vitiligo. It may seem counterintuitive, but a little bit of sun can actually be helpful in stimulating repigmentation in lesional areas. When prescription light source is not available for treatment, some physicians may recommend sunlight. However, the overall risk of skin cancers with sun exposure still outweighs its benefits, and it is important to educate patients about sun protection. There are various cosmetic camouflage products on the market, such as Dermablend or Covermark. Products range from self-tanners containing dihydroxyacetone to concealers to highly pigmented creams and powders. Dihydroxyacetone-based products can provide lasting color up to several days. Cosmetic camouflage is offered in a wide array of shades and colors to match the patient's natural skin color. It is important to note that these methods are temporary and must be reapplied frequently. Some cosmetic camouflages can wash away with water, perspiration, and have the potential to stain clothing. Parents and children should be encouraged to learn proper techniques of cosmetic application if this is something that they are interested in. This could be a great option for our patient, Annika, because her lesions are present in exposed areas, including her face and hands. Topical therapy is the first-line therapy for vitiligo involving less than 10% of total body surface area, specifically localized non-segmental stable vitiligo and segmental vitiligo. The main classes of topical medications include mid to high potency topical steroids and topical calcineurin inhibitors. They aim to repigment the affected areas via modulation of the immune system. The frequency and duration of therapy should be individualized. Some common regimens include clobetasol applied twice daily for 2 months, stopped for the following 2 months, and then repeated on a cycle. Side effects include thinning of the skin, mild atrophy, telangiectasia, folliculitis, or even hypertrichosis. On the other hand, for tacrolimus, which is a calcineurin inhibitor blocking the activation of T cells, it can be applied continuously twice a day until satisfactory outcome has been reached. Calcineurin inhibitors are preferred for the face, neck and groin, and areas where adverse effects are more common with topical steroids. It is important to note that repigmentation is a slow process and commonly originates from the hair follicles, as there is a reservoir of melanocytes in this location. This also explains why leukotrichia is a poor prognostic sign. Repigmentation from treatment will often look uneven and speckled. Make sure to explain this to patients and their caregivers so they have realistic expectations of the treatment regimen.
Phototherapy involves exposing the patient's skin to controlled UV light on a 2 to 3 times weekly basis for a trial of several months. If repigmentation is noted, UVB therapy can be continued for 1 to 2 years. It is considered first-line therapy for older pediatric patients with extensive vitiligo, as it helps with both the repigmentation and stabilization of disease. The clinical course of vitiligo can be unpredictable. Stabilization is especially important as it gains control of the condition at its early stages before widespread distribution occurs. Therefore, UVB is considered a cornerstone treatment for vitiligo. In addition, phototherapy can also be used in disseminated disease and localized recalcitrant vitiligo. Treatment is well tolerated in older children, but side effects may include erythema, pruritus, and phototoxicity. The 308 nanometer excimer laser provides targeted laser treatment for localized vitiligo. To our knowledge, there is currently little evidence in support of laser over phototherapy, but it could alter the course of treatment of vitiligo in the future. Low-dose oral steroids including prednisolone, betamethasone, and dexamethasone can be used in the stabilization of rapidly worsening disease, but the current evidence is limited. It is not a repigmentation therapy, therefore it is often used in combination with narrowband UVB therapy. Since vitiligo is difficult to treat and can have significant impacts on patients, it is not uncommon to see caregivers seeking complementary and alternative therapies, including vitamins, alpha-lipoic acid, ginkgo biloba, or polypodium leucotomos. However, the current evidence for those therapies are very limited. An open discussion of potential risks and benefits of those therapies with patients and their caregivers is very important. Autologous skin grafting is a surgical therapy in which a skin tissue graft is transferred from unaffected area of the body to the site of vitiligo. There are various grafting techniques, including tissue and cellular grafting. Complications include cobblestoning of the skin graft, potential scarring, and pain. Surgical grafting is typically reserved for a specific cohort of patients. A suitable candidate would be a patient with stable and localized lesions that have been resistant to other methods of therapy. It is often contraindicated in pediatric vitiligo because lesions are more likely to progress during childhood, and there's a risk associated with general anesthesia in children, which would be required for this procedure in young children. There is strong evidence suggesting the association of vitiligo with anxiety, depression, and other psychiatric conditions. Patients may face long-term social discrimination and be in a constant fear of disease progression. These factors contribute to the decreased quality of life and significant psychosocial burden. Children, especially adolescents, should be screened for mood disorders and psychological symptoms and referred to relevant specialists should be made when appropriate. In terms of treatment, psychotherapy such as cognitive behavioral therapy has shown to be effective at relieving the psychosocial stress. Counseling can also help patients better control their anxiety symptoms. The overarching goal is to improve patients' quality of life and help build resilience. We hope you found our podcast helpful and learned something new. Here are some quick take-home messages for you. Number 1. Vitiligo is the most common depigmentation skin conditions affecting 0.1 to 2% of the general population, with half of these cases presenting during childhood. Number 2. Vitiligo is an acquired autoimmune condition that leads to the destruction of melanocytes. The common risk factors include family history of vitiligo and other autoimmune conditions, as well as other environmental factors like skin trauma, sunburn, and emotional stress. Number 3. There are many subtypes of vitiligo, and the most common form is non-segmental vitiligo, which presents with bilateral white patches of skin in many areas of the body that makes up 80% of total vitiligo cases. Number 4. The diagnosis of vitiligo can be made clinically with thorough history, skin exam, and wound lamp, and a skin biopsy is rarely required. It is important to screen for other autoimmune conditions and psychosocial impacts. Number 5. Treatment options for pediatric vitiligo include cosmetic camouflage, topical steroids or calcineurin inhibitors, phototherapy, oral steroids, and rarely surgical grafting. This concludes our discussion. Thank you for listening to PedsCases podcast.
Check out www.PedsCases.com for more great podcasts, videos, interactive cases, questions, and more. Press subscribe on iTunes to get access to all of our podcasts. If you like what we do, please leave a review on the iTunes store, share with your friends and colleagues, or think about getting involved.